This conference will now be recorded.
Hello, this is the AnCan high-risk recurrent advanced prostate cancer call. It's April 24th, 2022. I'm Ben Nathanson, the moderator tonight.
26th, April 26th.
26th. Why did I write 24? Thank you.
Close enough.
So the first person who wanted time tonight was Peter Kafka.
Okay, I'll make it quick because I've got the Spectrum coming to troubleshoot my internet. At a certain point in this game or journey or whatever you want to call it, you kind of take the reins somewhat yourself, and that's kind of where I've been for a while. So following, I kind of keep step with Len on this one because we've got similar profiles. So I've been on monotherapy darolutamide since August. I stopped taking Lupron that last August, so I've just been on darolutamide. And I got to the point recently where I was just kind of tired of these LHRH drugs, these ADT drugs. It was just wearing me down a little bit, lack of testosterone and so forth. So my testosterone was coming up a little bit, so I decided I'd try cutting my dosage in half last month, about a month ago. So rather than 600 milligrams a day, I started dropping it down to 300 milligrams, a pill in the morning and a pill in the evening, just to see what would happen. I didn't talk to my doctor about it, and just did it. And 3 weeks later, my PSA has been holding for about 3 months at about 0.15, pretty steady there. But I was just getting tired of the lethargy and the down feeling I had about an hour or two after I took the drug in the morning, particularly. So I cut it out, cut it in half, and I did a blood test last week, and lo and behold, 3 weeks into it, my PSA doubled. It went up to 0.3, and my testosterone went up about 25 points. It's up to 72 now, and I said to myself, well, what should I do? Should I risk it? Should I, roll the dice here? Should I keep going? And I decided to bite the bullet and go back on the full dose of darolutamide. So I still haven't told the doc yet. They'll next appointment, they'll see my blood test results and kind of suspect something's going on. But I'm just going to do another test in about 3 weeks or months from now and see if taking the double darolutamide makes a difference, or whether I've gone castrate resistant or whatever. I'm not panicking about this. I was a little disappointed, but it's at some point you just got to take the wheel into your own hands and drive along on this journey yourself. That's my attitude anyway, and not always depend on the doctor, because the doctors at this point, there's no studies or definitive stuff that says this is what you're going to have to do and this is going to work, but long-term ADT is a drag. So that's my report.
Peter, did you stop Lupron with your doctor's knowledge and agreement?
Yeah, he knew I stopped Lupron. Yeah, he was okay with that.
He was okay with that,
yeah. And and they know that I'm willing to go get a PSMA scan if I have to. I've actually got the order sitting in my my file, so I can, probably when I get to the mainland Minnesota, I'll probably do a PSMA scan. Now that if my PSA stays up, it should show something, but I'm okay with it. If I need to go back on Lupron, I'll do that. If I have to, whatever I have to do, but I'm trying to do the least.
When did you stop the Lupron?
Peter, how long has it been since you were diagnosed?
8 years. About 8 years ago.
Okay, because I feel for you, because I feel that way, but it's only 3.5 years for me.
Yeah, I know. And I've been on and off several times, so I'm not afraid of it. So. I've probably gone off of all the drugs about 3 times over those 8 years. Lasted maybe a year, maybe 18 months.
So Peter, my understanding is you're now on half. You're on 300.
No, I'm back on the full dose. Back on the two 300s in the morning, 2 300s in the afternoon, in the evening.
Peter, this is Al. What was your testosterone when you went at the time you went off the Lupron?
It was down in the low 20s or something, and then it started going up, and I think it was 46 a month ago, and then last week it jumped up to 72.
But the your PSA was steady until you dropped the darolutamide dose.
Right.
Interesting. But you are working on darolutamide alone still, even with the rising testosterone.
Right. Well, this is the first time it went up. The testosterone went up. Well, it's been going up a little bit. I think I think just darolutamide tends to let the testosterone float up. I mean, I think Len has that experience. Len's off it altogether now, everything. But I think even on darolutamide, his testosterone was going up. So that doesn't surprise me.
Well, I mean, it should go up.
Yeah.
I mean, it's hard to know what moral to draw from the story. You know, testosterone.
Yeah, there's no moral. I don't think. I'm not telling you to follow me. I'm just reporting in, telling you what I'm doing.
How do you feel, Peter? Do you, through the various stages adjusting your medication, was it worth the risk, so to speak?
So far it is, yeah. I mean, I was feeling a lot better taking the half dose, but as soon as I went back on the full dose, I could feel it in the morning. It's almost immediate. I'll take a couple of pills in the morning when with some toast or something, and I just feel the drop in energy within minutes. I come back up, but just 2 hours of lag is pretty dramatic.
What do you do?
I take my abiraterone in the evening, and by the morning, I really don't feel that much of fatigue. I don't know if anybody else takes it in the evening or not. Just I'd throw that out there.
How long is that fatigue, and how bad is it? Do you go around functioning but feel exhausted, or do you have to lie down?
No, usually not. I just feel it like if I'm driving, if I go to town, I'll feel a little sleepy in the car. I mean, I can weather it. If I go to the gym, I'm kind of pushing myself, pretty hard to just my energy just goes down. And part of it might be my low hemoglobin, which I've been fighting ever since the beginning of this. I mean, that's another aspect of it that I can't beat.
I mean, Peter, my guess is that that's a big contributor.
Yeah, I think so. On that one, I've tried everything except standing on my head for lengths of time. I don't know how to beat the red blood cell hemoglobin hematocrit numbers.
And did you choose darolutamide because it was supposed to have less side effects than the abiraterone or the enzalutamide?
I did abiraterone for a year and I didn't like it at all. It's just too much brain fog, and this is much better for me. At least I can remember the name of the drug.
Hey, Peter, this is Julian. I take the darolutamide and I feel the same thing in the morning, but I force myself to go walk 2.5 miles every morning and I feel better. But
right,
I don't walk over the weekend. It really catches me up on Monday, but I'm also taking Orgovyx at noon. But it's taking some time to get through the symptoms because I was having diarrhea at first, and now I'm kind of clear on that. So I feel what you're feeling.
Yeah, I mean, I think you build up tolerance to it.
Yes.
I think in another week or so I'll be fine. I'll be used to it.
Any steroid like prednisone that might help with it?
No, I'm not. No, I think I can muscle through this, and it's fine. It's not a big deal. I'm just more interested in the numbers. You know, seeing if my PSA will drop down again next month. I'll let you know.
Thanks, Peter. Anything more?
Well, that's it for me.
I'm sorry that didn't work out the way you'd hoped.
Well, you can't be the first guy who's tried that. And
No.
I am sorry it went up. What is your hemoglobin in your hematocrit?
My hemoglobin floats at about 9, which is pretty low. And what's my hematocrit? About right in front of me here. Hematocrit's 29.4.
I mean, Peter, that is my guess is that that's a good contributor to being tired, to fatigue.
Yeah,
Especially if especially you're physically active, and it just takes its toll.
Yeah, it does, but I don't know of any secret thing to beat it. I mean, it's not an iron deficiency. I've tested that, and it just comes with the territory of ADT for me anyway. At least with I might have inherited it from my dad. I don't know. He was always anemic. But
go avoid caffeine or try to extra caffeine when you get that tired, lethargy, or you don't want to do that.
Yeah, I've tried it. Caffeine is okay. I'm gonna duck out because I got the Spectrum guy pulling up my road here. So I'm just gonna go talk to him for a little while. But I'll be back.
Thanks, Peter.
Thanks very much for listening, guys.
Thank you.
Jimmy G, you have the merest slip of a memo for us.
Yeah. Well, we don't have any new guys tonight.
I don't think so.
Maybe I'll give the full report. Except that the parts of it that I don't like are kind of uncertain, so I'll just gloss over those real quick. I have some swelling in my scrotum where I had the AUS, kind of like I did when I first had the surgery. And it's not painful. There's a little redness around where the shaft meets the head of the penis, whatever you call that. And I've been using this, whatever it's called, antifungal, clotrimazole and betamethasone. For that, a little bit better, but I still have swelling down there. I don't know if I want to contact the urologist for that. I'm supposed to go in and get the injection teaching session with hopefully a attractive young woman PA, but I don't know who I'm going to get for that. But I'm going in for that as soon as I can. But I kind of want to, I want my penis is swollen around the shaft. The shaft is not as long as it was, but it causes there to be not much air can get down there. So I try to keep it clean, but it's kind of lumpy and it's just not quite right. So I have that, and then also I have a lot of stiffness in my neck, and my PCP sent me for a DEXA scan, but they screwed up and gave me one only of my hip, where they disclosed that I have some mild osteopenia in my right hip, which surprised me because of my habits. But I think that it's kind of borderline, and also I'm a believer that the effects of androgen deprivation can last, and that it's a nasty hit. It's a nasty hit for us all, because when I went in to start a treatment, I got a DEXA scan on my own. They didn't give me one at diagnosis, but at that point in 2019, my T-score was 1.5. If you know anything about T-scores, that's pretty good for a 64-year-old. And now, I'm sitting there with some mild osteopenia in my femoral neck of my right hip, which is not the one that was replaced. There's a number of possibilities. I'm not too worried about it. It's kind of early yet. I just get back in the gym, do some more. What I'm curious about, so a guy's experience with naturally, advise that I take calcium and vitamin D supplements. What I've read about this is controversial. A lot of guys take them for bone strength, but other people will say that there's no good data that that's really efficacious, and that it's great if you actually have low D or low calcium, but as a preventive and as far as bone health, that's kind of a fable at worst and maybe uncertain at best. If anybody knows about that, they can talk about that. But that is only the bad stuff. The best stuff, of course, is I have my my quarterly, and it has now been 18 months since I was off of since I had my last shot of Eligard, and a year almost on the dot since return of full testosterone, and I'm still at a less than 0.04 PSA. And my testosterone is about 550. So, you know, as things go, that's not something to do anything other than celebrate, obviously. Anything else that's going on, I don't know. There's always something, as they say. But in other words, I'm doing fine. If anybody has any information or experience, probably not with this swelling of the scrotum after AUS, because most of you guys haven't had it. And those are guys that have AUS, at least the one that I see in the corner of my screen, which I'm not going to name, is the only one that I know that has had it. But as far as the, you know, the bone density and what comes short of Zometa or Prolia is for a lot of guys, vitamin D and calcium supplements. So any illumination on that would be nice. And that's my story today.
Did you have a bone density test at the beginning of your treatment at all as a baseline measurement?
I had DEXA scan, as I said. I had DEXA scan at the beginning. I had DEXA scan at a year, and I had a DEXA scan at the end of my treatment. And then I just had this one. It was erroneously done at my hip. But he wants my spine because my neck is very stiff. So I don't know what that's about. But yes, I had him along the way. And yes, the T-score gradually lowered, but it didn't lower to anywhere near osteopenia.
Good.
So it was very good, and now it's not as good. And, you know, I know there's advancing age, but given my diet and my exercise habits, I was still a little surprised about that.
Well, this is the guy in the corner. And I think that despite the controversy, it would be wise to take something like 500 or 600 of calcium twice a day with food if it's calcium carbonate and a little vitamin D. And I think it was because of your age and it's just taking a while to recover despite all your exercise. And as far as the other thing is concerned, sometimes I have pain where the device is if I do heavy lifting, but it's been a 6 months, I think, since I had that lumpy swelling, which I had after the procedure, which was disturbing, but gradually went away over the month or two after the procedure. So I haven't had that lumpy swelling anymore. But you do lift heavy weights, and maybe something happened. I had one time where I had a particular outbreak of pain, but the guy examined the device and said I hadn't damaged it or anything like that. So probably you do have to go back maybe on your appointment for the injection. You should turn it into an appointment for an assessment of what's going on, because you sure don't want an injection through that swelling.
Agreed. It's more important. I think I'm going to try to get a urologist to look at that before I do any of this injection stuff. I appreciate that, John. And I know that it's not so much heavy weight, I think, but both working out hard in general and performing. When I perform, I'm prancing around like an idiot. And it's a long night, and I feel like Dusty Baker, the baseball player, used to say about Hank Aaron. he was a rookie when Hank Aaron was in his last year. And he said, Hank Aaron, before every game, looked like Fred Sanford. As soon as the game started, he looked like he was 18. And when the game ended, he looked like Fred Sanford again. It's exactly how I feel when I play shows. I get there, I am ready to go. I could not feel any better. I might as well be 18. As soon as it's over, I'm Fred Sanford all the way. So, including the next day, I'm a little more swollen down there. So always is kind of something going on there. The other thing I want to.
Well, the jumping then. It's the jumping.
There's
It's
a lot.
it's that third set, Jimmy.
We cut it to 2 sets.
Well, maybe it's more the landing than the jumping.
Yeah, it's the jumping, it's the prancing around. The audiences have been very enthusiastic lately, and I'm a ham bone at heart. So if they feed me the energy, I got to feed it back. But John, what do you say about calcium twice a day? Is it an absorption thing?
Yeah, you can't really absorb more than about 500 at any one time, so you have to divide the doses.
We were taking it because abiraterone eats up your calcium.
Right.
If you're not taking anything, then calcium may be of no benefit to you right now. Vitamin D may be, but
Well, I'm not
it depends
sure,
on what
Jeff.
drugs you're on.
But he has
I
some
think-
catching up to do on his bone
Yeah.
calcium according to his scan. Sorry, Herb, what were you saying?
No, I was saying the same thing, John, that I think you should be taking, if you have any issues at all, take calcium. It's no big deal.
Well, you say 600 twice a day or 600 broken up?
I'm taking 600 twice a day.
And that's what you said, John, also?
500 or 600 twice a day. Yeah, we should be taking probably 1,000 to 1,200. It's kind of interesting. I was looking at, doses and found, I can't remember what it was now, but I found at least one reference that said that higher doses than 2,000 was it? Anyway, but high doses of calcium are actually associated with a worse outcome for us in terms of prostate cancer.
Yeah.
So it's good to hit that
old
middle sweet
research.
spot.
Yeah, that's
That's
old
old stuff.
research, John. Yeah,
Okay.
I recall reading that back around 2007, 2008 when I was diagnosed, because I'd always had a very high history of calcium, serum calcium, not very high, but it was always slightly above normal and never dropped. And when I was doing the research at the time, and I may even have that article somewhere, I'll look for it. But you can find it on PubMed. If you search on PubMed for calcium and prostate cancer, it'll come up. There is a correlation between high levels of serum calcium and more aggressive prostate cancer. I don't know why. One reason could be that high levels of serum calcium create calcium stones in your prostate, and they may irritate, they may aggravate, and that could be a reason. But I know at the time I was told that they could see calcium stones in the prostate.
Oh.
When I started on Abbey, I had to speak to a pharmacist at Kaiser, and they were very clear that I should not, that if I took more than 500 milligrams of calcium, it wouldn't matter. My body wouldn't absorb it. And I had to take it twice a day. And they wanted to make sure that the timing was far enough apart so that it would get absorbed both times. So maybe they've changed that 1,000 works, but they were pretty specific that your body can't absorb more than 500, and that 1,000, the other 500 is just wasted.
Yeah,
Well,
but some of it is a function of vitamin D, because you need vitamin D to absorb calcium, and a lot of men with more aggressive prostate cancer have low levels of vitamin D, and again, you should be testing your vitamin D, D3 hydroxy 25 on an annual basis, if not twice a year, and you should be adjusting the dose of supplement of D3 that you're taking.
Interesting.
Plus, anytime we talk about 1,200 or something like that per day, it should be understood that we're talking about divided into 2 doses, just like Jeff said.
I got one more thing that may be of interest. I got on statins because my LDL was screaming high at about 224. I tried to work on it on my own. I went to 252, and that's very high. And I think I got familial hypercholesterolemia. So anyway, I went on a Crestor and I cut it in half. I was tested 117. My brother is a retired doctor, says that isn't low enough. You want it to be about 70. And I told my doctor this, my new PCP, all 34 years old worth of them. He said disagreed, and that he thought that you didn't want to bother that until it bothers you. So that's a small controversy in my life. My retired doctor, who was a doctor for much longer than this guy's been alive, of not necessarily of any consequences, at odds with that opinion.
I don't know. I'm with you, brother.
No, it's not a function of the absolute level. It's a function of the ratio.
Yeah. So
It's a
what's
function of the high. Herb, I'm in the middle of the sentence, man. It's a function of the amount of high density cholesterol you have relative to the total. So if you have, as in my case, I just got tested. My high density was 100, and I think my total was 220. So I was at 2.2. Now, if you cut it from 250 to 125,
117.
the question is how much of that is high density? If your high density is down to 20, you've got a problem. If your high density is at 60, you've got a good issue.
You know me, right?
And also, what's your high density?
75.
Okay, so if you've got a ratio of less than 2, it ain't going to get much better than that. Guys, I want to be sure that we get to Steve Saft whilst Herb is still with us. And we do have one new gentleman as well. But let's cover Steve before Herb leaves, because it's an important issue.
I'm out. I'm at more time than I've ever had. Thank you, though.
Good evening. Am I on?
You're on.
Okay. So I think it's been at least 4 weeks since I've been here, and in that time, I was supposed to start on April 14th a clinical trial with a combination radionuclide therapy, lutetium, about the same dose as Pluvicto is, plus actinium-225. Unfortunately, somewhere between April the 7th and April 14th, I guess I got sick, and my AST, my liver enzymes rather, elevated to 110, which is really the first time I've ever been out of range on that. I felt lousy during the week that I was, the 4 or 5 days before the 14th. And anyway, to make a long story short, I couldn't get it. So I came home and continued to feel lethargic, tired, sleeping a lot. I have gotten better every day. By the middle of the next week, the AST was back to normal. And they scheduled me to redo this alpha beta trial of the actinium alpha radionuclide, and the beta is the lutetium, on May the 12th. I have been investigating the possibility of starting a straight Pluvicto program somewhere, and I think I'm going to hear tomorrow whether I get in, what their thoughts are in Houston. But for the time being, I doubt very much whether I'll get anything before May 12th. And so I am feeling a little better. I'm in a lot of pain. I really have a large load of metastatic disease throughout my skeleton, lower back, thoracic, neck, so forth and so on. By the way, Jim, I think you should trade the stiff neck for the stiff penis. Um,
I thought you would give medical advice on here.
right. But at any rate, like I said, it's been a rough couple of weeks. I think the last time I was on, April the 8th, my wife had a double mastectomy, and the surges of adrenaline and crashes and stress and whatever. I have no idea what caused the liver thing to go up. Perhaps I was taking more Tylenol than the pain medication that I had been taking, because I was sitting in the hospital all day on the Friday she had the operation. By the way, she's bounced back very nicely. She really is remarkably well. We had entertained 15 people that Friday night, a week, 8 days after her surgery here. So really quite pleased about that. And now, in talking to Rick and Herb, you know, the way this combination therapy works, if I get the dosage, hopefully, if nothing else comes up sooner, then I would get week 1 would be May the 12th. 8 weeks later, I would go for the second treatment, which would include the 2 doses, and then they watch you for another 8 weeks. And at this point, I don't know whether I could get into a regular Pluvicto program after that. And so I spoke to Cora Sternberg last night, and she seems pretty confident that the way things are set up for me, that there's a good chance, no guarantee, but a very good chance that the combination of the two could be effective. So that's the update. I'm going to go get labs tomorrow at LabCorp, and hopefully everything will be within range. And then 2 weeks from Thursday, one way or another, I'm going to be getting something in the radionuclide family. So that's really my update at the moment. It's very difficult to manage the pain medicine, keep active, working. If I take enough to make the pain go away, I get more lethargic. If I don't take enough, I can't really sit for a very long time. So I am experimenting with different timing and different dosages, and when to take the extended release and when to take the instant release, but it's not that much fun. So that is my update. Herb, I know you had said that I guess there's 6 doses of Pluvicto. And theoretically, I guess if I get the alpha and beta over the first 8 weeks, that's 4 doses. I don't really know how you measure that.
Well, I'm not sure. I mean, I think time count, repeated doses and, the way things, at least my understanding, the way a lot of anti-cancer medicines work, is that it's sort of percent kill. So each time you give a dose, you want to kill off as high a percentage as you can. And so that's why all these regimens that we're taking are repeated rather than a single dose where,
right,
like an antibiotic, you still take it for 7 days. So I guess my own sense is, given your situation, Steve, it would be whatever comes first. If you could get Pluvicto sooner, because it's proven, and because of the other side effects we've heard from people like Carl, right? One wonders what the effects might be, whereas at least Pluvicto, it's more or less it's understood from a larger trial. But the question is how soon you could get it.
Yeah, I am feeling that pressure intensely. And certainly, I'm sure everybody can understand what a kick in the stomach it was to be up there, and then have to come home with nothing.
Well, it's like the kick that I got when they called me the day before and said the drug is bad. So,
right.
but my sense is, like, given the pain you're having and everything, the Pluvicto, as you point out, the dose that comes in the combination is for lutetium is the same, and you're
Right.
getting this added actinium. They're stretching it from 6 weeks to 8 weeks versus, and my sense is after 8 weeks, if you still needed it, I would not see why you couldn't continue with Pluvicto.
Yeah, well, Weill Cornell, as my understanding from Rick is, they have it for general use, not for a clinical trial. But Cora was just back from Italy for Passover in Italy, and she didn't know anything about that. So I'll speak to her again tomorrow.
Yeah, I mean, I think Cora should have a good sense of what's going on. I mean, if you could get either one at Cornell, then she should have some insight into what's the
Right.
optimum strategy. Now,
Right.
Rick tells
Yeah,
me you can
but
also get it in Maryland.
Yeah, I didn't. I mean, I have the number to call, but I didn't call today.
So a couple of things here, and I'll go through what I found out speaking to advanced accelerator applications a little bit later. But first question in my mind, which is certainly above our or maybe not above her, but certainly above my level, is I don't know how much radionuclide dosimetry they can administer. I mean, the only person who's here in the group tonight that I know that has gone from one protocol to another is Dennis McGuire. And maybe we'll go to Dennis and find out what the discussion was between Carbone and University of Chicago. But, you know, a concern that I have is if you've gotten the alpha plus the beta, can your body take, how much more can you take? Can you take another 6 doses? That's the first thing. The second thing is, I can't imagine they're going to be very happy at the trial because it means that they've got to cut off measuring you at the end of 16 weeks, because anything you do after that's going to be contaminated because you're getting more lutetium. So I mean, to me, there's an issue there, and it should be addressed now rather than later, because you don't want to find that they're going to say, oh no, you know, you find something, you can't do that. And,
well, I mean, I know I can pull out anytime I want, but again, the dosimetry thing is really something. So I will ask. I wanted to give her a chance to get settled today.
Yeah, the other thing is that I hate to say it, but I don't know that he's. I mean, I feel that Dr. Sternberg has a conflict of interest here. She's in a very difficult position because while Cornell knows that she's talking to Steve, he knows that they've got a 60-year personal relationship, and if Steve suddenly moves over to the Pluvicto trial, she's not going to look very good with Tagawa, who's trying to recruit people. And you know, again, I know you guys don't take this seriously, but this conflict of interest is a big issue.
Oh, I think it's serious as a heart attack.
It has to be considered. It's got to be considered. So I've said to Steve, I don't know that he can get an unbiased opinion from Cora, that maybe we've got to reach out to other docs and say, ask them, what do you think? And Dr. E also has a conflict because of her relationship with Cora. So, you know, I mean, happy to throw that one out to the group and see what you think on that one. And Dennis, maybe Dennis has something to say about how much radionuclide can be administered. Because Dennis, you went from a high dose lutetium over fewer applications, which didn't seem to do much for you. And then you followed that pretty quickly when they shifted you over to the regular Pluvicto trial, correct?
Yeah, that's right. So the first trial I was on, it was basically double the dosage of lutetium. and 3 treatments. And then I had a gap of 6 months before I went on the managed access, where it's, you know, the standard dosage and 6 treatments. I think for me, the passage of time of 6 months kind of reset the clock from my doctor's perspective.
What do you mean by that? Reset the clock?
Well, so I've had, you know, I had 3 treatments on the first trial. I've had 4 treatments on the managed access. So I've had 7 treatments, which is more than the vision trial, which was 6.
I mean, so again, that's the accumulative effect that Herb was talking about as you keep taking it, even with the 6-month gap?
I don't know. No one knows. You know, this is new territory.
Can I ask you another question? What does it look like when, you know, Pluvicto or the lutetium starts to work in terms of, you know, where do they see it?
Well, they see it, ideally they see it in a PSA drop, Steve.
Yeah,
I had
a quick response to the lutetium in both instances. Even after the first dose, my PSA dropped close to 50%.
Okay. And anything else? I mean, or any regression? And do you have metastatic disease?
I do, in lymph node. I also, in addition to PSA testing, when my burden was pretty high and my PSA was 300 in December, I could physically feel
cancer growing.
No, the lutetium working.
Really?
I mean, I had pain in certain areas of my body where I knew the lesions were.
So that was good pain because that's.
Well, yeah, apparently.
Okay.
Yeah.
I'll sign up for that. Sorry. Okay. Again, you know, going back to Rick's point about trying to find somebody that doesn't have a conflict of interest that really will give me an answer. I think I'll put together a note and ask the various different oncologists that I'm involved with. I'm certainly involved with enough. And if anybody has any ideas who might be a real unbiased umpire on the subject, I'd like to really know a little bit more about actinium and so forth and so on. Dr. Narayan, who happens to be away this week, I mean, he's a big fan of the combination trial also.
Well, that's a sign.
So.
And I know you won't talk to Kelly, right? I mean.
No, I talked to, actually, Kelly called Mount Sinai for me to see if he had just given a lecture there, and he called Sloan Kettering, Mount Sinai, NYU, and what they told him was that they've stopped the compassionate access, slightly different terminology than the managed access that Dennis was just talking about. But, you know, for the moment, and actually Kelly told me June 1st, they're going to have Pluvicto get it started around June 1st at Jefferson. So, you know, he was nice enough to check in and see how it went when I went up to see Cora, and we talked about it a little bit. And I really was so lethargic that I wasn't as aggressive as I typically am in terms of responding and searching and researching. But I feel better now, and I'm starting to both do more work and do more work on this stuff.
So
Bryce Olson is a guy that
maybe you
really
could,
is not. I'm sorry, who was saying something?
I was going to say to her, maybe you can reach out to Martin, what's his name at Hopkins?
Yeah, I could.
What's his last
Pomper,
name?
Martin Pomper.
Yeah,
Pomper, right.
I mean, the other thing I could do is I do have an appointment with Carducci on Thursday, and I can talk to Carducci about this.
okay. I mean, I would certainly appreciate that. And
I mean, I
actually,
think
my
Carducci and I are on good enough terms. I think he would talk to me.
well, going back to, I'm not burning any bridges as upset I am with Dr. Kelly. I felt like I handled, our separation, divorce, breakup as well as I could. I mean, I looked him in the eye and I told him what it was and how it was and where it was. And actually, one of the things he said to me was that they basically, which, I almost screamed, but I didn't. I kept a straight face. He said that they treat every new prostate cancer patient the same, and that maybe it's time to revisit that approach.
No shit.
I mean, it's strange that I record all these conversations, and for whatever reason, I forgot to press record that day. I guess I was pretty uptight, but it was unbelievable to me that he said that after, the back and forth that we've had over the last 9
Well,
months.
but also over the back and forth and all these new trials that have come out about it, how to start therapy with triple therapy, like Arasens and things like that. How could you even say that?
That's why I'm repeating it. It was bizarre, especially to say to me, especially after I went and got all these scans everywhere else. But all three of the scans. Now since March the 4th, I've had a Polarify, an FDG, and a gallium-68, all of which are confirming that almost everything that is cancerous in my bones and body is expressing PSMA.
Then I think one of these nucleotides is obviously the right thing. And
Right.
then the real question is, let's say you had to wait for Pluvicto. Let's say the decision was, well, you can't get Pluvicto so soon, but you can get the combination in 2 weeks or May 14th.
Well, if
Then that's an operational decision.
right. Well, it would make it a little bit easier. I guess Cora's saying that she thinks that the combination is really a good alternative for me. And that's what she said last night. My wife happened to listen to the phone also on the speakerphone. It was like 6:30, 7 o'clock, and it made her feel better. I can't say I feel all that much conviction one way or the other at the moment, and I just hope I don't crap the bed again with my labs.
Okay, we do have to move on. Is there anyone have any final questions for Steve? Okay, so the next person, Mike Yancey. I'm sorry, I did not recognize you from last week. You were an observer last week, and now you wish to speak. So we have, as you've seen, we have a set of questions that we ask new people.
Okay.
And if you don't mind, we'll go through those.
Sure.
Starting with, how old are you?
65.
And where do you live?
I live in Northeast Oklahoma, about an hour and 15 minutes out of Tulsa.
And how did you hear about AnCan?
Actually, heard about AnCan through another meeting that Rick Powers started hosting, and I found through LinkedIn. And Rick was on that particular call, so when then I got on the AnCan website, and that's how I found you all. And last week was the first time that I attended one of these meetings.
Well, welcome. It's nice to have you here.
Thank you.
What year were you diagnosed?
I was diagnosed 10 months ago. I was diagnosed in July of 21.
And your Gleason score and PSA at that time?
No Gleason score, because we haven't done any biopsies or anything like that. One of the things I was going to share as I kind of went through my journey here, was my PSA, interestingly enough, because I've always gotten a physical every year. Like in 2019 or 2016, it was 1.3, 2019, it was 1.2. And then in September of 2020, before I was diagnosed, my PSA was 2.3. And a lot of detail, which I can share later. But when I ended up in the hospital in early July of last year and was there for about 11 days, my PSA was in the 400s.
So what was your first treatment?
Okay, basically, they started me on because I had significant metastatic disease. My spine, my pelvis, my right leg, and so to manage the pain, I went initially with 10 rounds of radiation and started 6 rounds of docetaxel at the end of my radiation. And I should back up and say that I also started Lupron at the same time I started the docetaxel. And so that's I completed my docetaxel November 29th was my last treatment. I'm continuing, of course, on the ADT with Lupron. And 2 weeks ago, I started, can't even say it right, abiraterone.
You got it. And what doctor are you seeing now, or whom you seeing? What is his or her specialty?
Well, I'm seeing currently locally. I'm seeing a gentleman here in the Tulsa area. He handles all types of cancer. And then February 8th, I actually had a meeting down at MD Anderson with Dr. Pilie, and spent, I'm gonna say 4 hours there. Was less than overjoyed with what I saw there, but I think we're at this point we're still maintaining a relationship anyway. So that's why why I wanted to go through everything I've got here to kind of get your all's opinions, thoughts, and maybe recommendations.
Yeah, just try and stop us. Did you get genetic testing?
I have had genetic testing. That was an outcome of my meeting at MD Anderson, and everything came back negative on the genetic. I've asked about sequencing, and interestingly enough, I've basically been told, and I'm not sure I believe this, so I'm looking for your all's input, is that because my cancer is currently under control, my PSA has been running, 0.09, 0.07, 0.1, 0.12 over a period of months here. And so everything's working, and I've basically been told on the sequencing, wait until it comes back, cranks up again.
I can understand that.
Can you? Okay, so you're kind of agreeing with that commentary.
Well, Rick is going to give you his opinion, and that's the one that really counts.
Now, one thing they did do, the only biopsy I had done was on my bone marrow when I was in the hospital there, and it came back with a whole bunch of information here. Tumor cells positive for AE1, AE3, PSA, and negative for CK7, CK20, TTF1, GATA3, CDX2, P40, and CD56, which you all may understand that I don't.
We're almost through with the questions. Do you have relatives with cancer?
No.
And do you have questions for us?
Well, basically, I guess I was just kind of interested in your all's perspective and the fact that, I had no symptoms before I ended up in the hospital. I actually was down because what happened is I initially had such significant pain starting in June that I went to a little rural hospital, and believe it or not, they misdiagnosed me as Lyme disease. So I got 2 weeks worth of doxycycline, went home, was in bed for 2 weeks, got no better, went back. They said, well, all we can do is give you 2 more weeks, and went home, and the next day I couldn't stand. I was in such pain. That's when my wife called, and I ended up with a free ambulance ride to Tulsa to the major hospital there, which is where I was at for 11 days while they started running every test in the book to figure out what was wrong with me.
Who was the doctor you said you saw at MD Anderson, Mike?
Dr. Patrick Pilie,
How do you spell that last name?
Pilie.
Pilie.
L- Correct.
Pilie. And not a name that I recognize. Have he been there a long time? Did you ask? Do you know anything about him?
Not sure how long he's been there. I actually ended up getting kind of recommended to him through actually a relative who worked there about 6 years ago, and she reached out to some of her colleagues to see who they might recommend I try to get hooked up with. So that's how I ended up there.
Okay. I mean, I do know a whole bunch of the genitourinary medical oncologists at Houston, at MD Anderson, but that name is not one I've ever heard before. So I mean, I'm assuming he's a GU medical oncologist. Just because I don't know him doesn't mean he isn't. But I just haven't come across his name before. George Rovder, thank you, my man. George Rovder looked him up. And what do you find on there, George?
I just gave you the link. I'm sorry. I didn't read it.
Oh, you didn't read it. You just sent me the link. Okay. Well, one of our guys will look at it whilst I'm talking.
Nice picture.
I mean, there's a bunch of things here. The other question I wanted to clarify is you said that before they started the docetaxel, they put you on, they gave you some radiation. Did you say 10 sessions of radiation?
Yes, that's correct. All they were trying to do was not really do anything with respect to, I'll say, limiting the cancer. They were more interested in trying to manage the pain aspect of it.
Yeah, that's what I assumed it was palliative.
And
So
in fact, the funny thing, when the radiation oncologist brought up my original bone scan before, as I was counseling with her before we started the radiation, interesting thing, I still laugh about it. She basically says, "Well, that's not normal," and kind of was an interesting comment.
Yeah. Well, how are you feeling right now, by the way? We should ask that first, and we always forget to ask it. But how are you doing right now?
In all honesty, if you told me 8 months ago I can do what I'm doing today, as far as, because I'm pretty active, I would never have believed it. I do, unlike where I used to be able to do heavy work 10, 12 hours a day, I'm down to about 6 hours a day now. I do, since I started taking I was actually walking 4 miles a day before I started the abiraterone. But now, because you can't eat for an hour, I basically take it, go for a walk at 5 a.m. for an hour, come back, eat breakfast, and move forward. And then, of course, then my day has already started. So, like I said, I'm feeling great as far as that goes.
When you go out for that walk, would you say you get your heart rate up above to about 80% of max during that walk? Or at least 15 minutes?
Yeah, I've heard y'all talk about 115. I basically walk at 4 miles in an hour flat, sometimes a couple of minutes under. I'm just short of a jog. And so it's also hilly here, and so I'm up and down, and so I'd say that yes, I'm getting my heart rate up where it should be.
I didn't think you had too many hills in Oklahoma. Well, you might. What do you live in the?
I live to the east, not the west.
Okay. Just saying, just saying. I know there's a very nice guy who runs the rowing club in Oklahoma City. Really nice guy. Well, there's a few things here. I mean, I do think you need a really good quarterback. And, I think most people on the call know what I'm going to say, which is that we would send you to Dr. Xtandi at Houston Methodist, which is right next door to MD Anderson.
How do you spell it? Dr. who?
So it's somebody will put it in the chat window, Eleni Xtandi, and they'll put a link. George Rovder will do that. He's my link man today. Eleni Evstathiou, she's also on our advisory board. So you can look at our advisory board, you'll find a picture there. She was 14 years at MD Anderson, and she moved over just about a year ago now. I think it was last April or May. He moved across to Houston Methodist, and she's really, really on the money. I can't imagine Eleni saying that she would not sequence you. I mean, to me, it makes no sense for anyone to say we shouldn't sequence you, because it's the essence of precision medicine. And these guys are not living in the 21st century if they're not looking for precision medicine. And you have metastatic disease, and in fact, the guidelines say you should be sequenced. Now, does that mean that the sequencing could be different a year from now? It could be, yeah, because you're making these mutations yourself. The genetic sequencing didn't show anything, but you're making these, and that may well dictate the best sort of treatment. You may not be on the optimal treatment right now, but you may be, but we don't know until we do the sequencing. So you got to get sequenced, and somebody like Dr. E is going to definitely prescribe. And it can be done in two ways. It can be done either from solid tumor tissue, or it can be done with blood. And sometimes she does both. There's a reason to do both. It's technical. I don't want to get into it right now. But I think the first thing I would do, especially if you weren't especially thrilled with MD Anderson, which she will empathize with, I feel sure, I'd move your treatment over to her, make her your quarterback, tie her into your local oncologist in Tulsa, and then, at least from our view, you'd have a good team there.
Okay.
The fact that your PSA got down to 0.09 is great. That it's shifting around a little doesn't mean a whole heck of a lot, because it's not that accurate. So you're changing 3/100ths of a decimal place from 0.09 to 0.12. So that could be. So it seems like it's working, and the question is, we've got to keep it there. And are you tolerating the Abby and the are you on prednisone or dexamethasone?
5 milligram prednisone.
Once a day or twice a day?
Once a day.
Yeah. So again, sometimes some of these guys are on 2 by 2.5. Some are on 2 by 1. Frankly, I'm not sure I know the difference. That we've got something on the website that Len wrote a while back that compares all the various combinations. We tend to like dexamethasone a little bit better, but this is kind of fine tuning, as Julian will tell you. Moving between the drugs, but if you're doing, if it ain't broke, don't fix it. But I think the two things I would say, and then I really want to get some input from the guys, especially the ones who have done a similar routine to you, started with chemo, gone on to Abby, or started with Abby, gone on to chemo, is, just hang in there, get yourself a really good quarterback that you like, can almost guarantee, take your wife with you. I mean, she's really terrific. Some of the guys will talk about it. The only other thing that I would say, and it may be time around now, is to discuss with your team, whether it's with Dr. E or whether it's with local or both, about getting the the primary tumor treated. It can be treated with radiation or surgery. Probably radiation is the easiest way, but the thinking in terms of treating prostate cancer has really changed in the last 5 years. Chemo's given much earlier, as you found out, and no longer do we say that treating the primary is only going to do harm. We think that treating the primary tumor, the prostate, really sets the disease progress back. And normally they don't do it right away. They'll do it, maybe after a year, 18 months. Herb had his primary was diagnosed de novo metastatic and had it treated later. I think Jim Barnes had it treated later. I mean, a bunch of the guys who are on this call, within the first year to 18 months, they got treatment to their primary tumor. And that's something that somebody other than a genitourinary medical oncologist probably isn't even aware of. So let me invite anyone who wants to talk to Mike to speak up.
Well, I wanted to follow up on the genetic test. You frequently tell us that we shouldn't be doing testing unless it's going to inform the treatment. And you also pointed out we should not fix something that isn't broken. His disease is completely well controlled at this point. I'm not sure what's wrong with what they're doing or why we need a genetic test at this point to fix it. If
I'm not saying to fix it. What I'm saying is that there may be better medications that are indicated, and those indications could annihilate whatever cancer's still in there. I'm not saying you do it. I'm saying, yes, it is going to tell us something. Let's just say he has a somatic BRCA mutation. Say he has somatic BRCA1, right? Then we know that it might make some sense to look at a PARP inhibitor early, or let's just say, and probably not because he's responded well. It might indicate a different type of chemotherapy. Now, because he's responded well, does it mean we shouldn't look for what the right drugs are? I think it is going to tell us something. But you could argue not. I accept that.
The diagnostics get more sophisticated every day, and being able to tell small differences. I forget, what was your PSA 2 when you first got diagnosed?
Well, I mean, I had a physical, in October before I got diagnosed in July. And at that point in time, my PSA was 2.3. It actually had doubled in a year from 1.3 to 2.
Right.
1.2 to 2.3.
And that's when you were diagnosed at 2.3?
No diagnosis, no concerns, nothing. Good physical. And it wasn't until I went down with the pain and had been in bed for 2 weeks with fever and pain and got shipped off to the hospital that they started looking to figure out what was wrong with me. And that's when they came up with the cancer. So.
Right. Well, I would agree that at this point that I think that the more diagnostics you can get to see where it's attacking, why it's attacking, how it's attacking, and target your treatment. I think that it's not going to change the treatment regimen. Has got me in a lot of trouble. I would strongly suggest that you be aggressive and you ask your doctors to be aggressive in trying to figure out what is fueling the cancer in your body systemically.
I'm surprised they didn't do genomic testing before chemo. That seems weird to me.
That was something. I mean, once again, I was ignorant when I got diagnosed, and so other things other than chemo and the radiation, of course, there was really no discussion other than the fact that and the Lupron. So it's only been since I've gotten with groups like this that I've gotten some education about the genomic testing, et cetera. So I've learned a lot in the last few months.
Now the doctors are not always on this game. I had a guy who could have, who had a mutation here that I was helping out, and I leaned on his doctor because he could have taken another different chemo drug, but his doctor wouldn't do it, and he wouldn't speak up for himself. But it's a weird thing. So you got to push sometimes.
Yeah,
I understand what you're saying, that we're kind of ignorant when this lands on us sometimes, but the doctors can be just as ignorant.
Well, and that's the thing. That's kind of why I went to MD Anderson. I felt like maybe I'd get a little bit more input, a little bit more evaluation, if you will. And basically, when I called, set up the appointment, they said, figure I'm being here 3 to 5 days. And then after 4 hours, and all I was told, other than the fact that what he already knew about my cancer from my medical records, and the fact that I had been reading and studying all the other possible future treatments, Jetvana, and you can rattle them off pretty quick. He basically went through those kind of like a clock, kind of around the clock, if you will. And I'd heard and read about every one of them, so I learned absolutely nothing new. And in fact, when he talked about abiraterone, I'm the one that brought up the Piece 1 study and said, that sounds like it might be something that might be a benefit. And he kind of agreed, and so here I am today. I'm on abiraterone. But if I hadn't asked about it, probably would not have been.
Right.
Anybody have any words of wisdom, encouragement? A lot of you abiraterone chemo guys are on this call.
I think Dr. Elaney is probably a good move. The other person I thought of is what's his name, the young guy up in Nebraska. It's probably.
Oh yeah, Luke Nordstrom.
Right. Yeah, Nordstrom, right?
Yeah, he's good, very good, Peter. Yeah, another good choice, Luke Nordstrom in Omaha City.
Okay.
You might want to look him up. Nordquist, thank you very much. Yeah, he would certainly be another good option for you. So, look up the two of them. I don't know. I probably would go to Dr. E, but I'm biased. And anybody want to say anything about Dr. E? I mean, I don't think we've got any Nordquist patients on here right now. But
Dr. E is fantastic, wonderful, very aggressive in trying to figure out what has the best chance of being an effective treatment. And she was a godsend for me. I don't know, if I can say it any more clearly than that. She's very, very nice, cares about the patient.
Okay, well, I appreciate that very much. Thank you.
Les, were you going to say something? Okay, anything else for this?
Mike, are you on Medicare yet?
I'm sorry. What was the question?
Are you on Medicare, Mike?
On Medicare? Yes, I'm on Medicare.
Good.
Did you say you did not have a biopsy?
No.
Did they do an MRI? When I was first diagnosed, they did an MRI with and without contrast. Showed the lesions on my prostate. Is that just for my own education? Is that standard of care? Is that the first step? And it came back with a PIRADS 5 indication, which is the highest indication of cancer. Which led to the subsequent biopsy.
Right. I don't like it when they don't do a biopsy, because there's a lot of information that can be delivered from that biopsy, even when you have metastatic disease. But I don't. It's something we can talk about another time. I know we've still got 5 gents to visit with, and so we could unpack that one. So Jim Barnes, keep that one in your quill, and next time we say, do you have anything, you can say yes, I'd like to talk about biopsies for men who have diagnosed de novo metastatic, and we can go there. Okay?
Sure.
Well, thanks for coming, Mike. I hope you come back.
Oh, and I appreciate your time very much, and thank you for the input. Thank you.
Frank Fabish is next.
Hi, guys. Just a quick update on my enzalutamide that I stopped on April the 6th. My balance issues have gotten better, not better. I've had no balance issues. I've had no dizzy spells since that happened. My memory issues have improved a little bit. And I go back to see my doctor on May the 17th, and they'll run the blood draw and the tests, and we'll see where my test results are. And then at that time, come to a decision on what to do with it. I've remained on Orgovyx, and that I've been taking every day. But I know that I heard from, at least from my doctor's staff, that they didn't think that the enzalutamide would have that effect on me with the dizzy spells and the balance issues. But we went ahead and made the change to stop it for 6 weeks, and now we'll reevaluate in May.
2 points for AnCan.
Absolutely, and hopefully I'm pushing for them if based upon the results that they can get me on darolutamide with the Orgovyx. Again, an AnCan recommendation.
We don't give medical advice. Remember, Frank.
Right.
But let me
No,
say,
based on individual experience.
Right. Thank you. But let me just say that if there is a history like you have, that might provide Dr. Mortasavi with a very good case to justify why darolutamide is more suitable to you, for you, than enzalutamide.
Yeah. And they're going to take that information back to the VA to counter their argument that I should be on enzalutamide.
Right.
But anyway, that's my quick update, and again, it's AnCan coming through with their experience that helped me with what should be done.
So this allows me to make a pitch, which you know I like to do. Every year, we need to get at least 10 recommendations on great nonprofits so that we get their seal of approval. And we just started that process. And if you go to our website and if you click on testimonials, it'll take you through to the website. And if you click on share your story, we would love for you to repeat what you're saying here, provided you're happy. Well, I suppose if you're not such a happy camper, you should put it on too. And if you put it on before, you probably can't put it on again. But we need to build 10. Hopefully we'll get, not everybody is prostate cancer. We'll get people who are non-prostate cancer. But now's the time. If you're grateful for what we've done, please go to great nonprofits And I'll put the link in the chat window.
Yeah, I saw that today. I will do that tomorrow.
Thank you. Thank you.
I will also take time to get that done.
Thanks. It doesn't have to, some guys are writing long epistles. It doesn't have to be, it can be, but we're just grateful if you put it on there. We say thank you very much. We're truly grateful. And I'll put the link in here for you right now and hand it back to, but anybody else had, I'm really curious on this. Has anybody else experienced balance issues? I mean, I know people have had really bad brain fog from enzalutamide, and there's a new article that I'm going to link, I think, next week. I noted it. Mark, you've had balance issues?
Well, I'm on Xtandi and Lupron, and like I have to be careful going up a ladder because I just balance and spatial awareness is not real good.
Yeah.
Rick, this is Joe.
Yeah. I mean, yeah.
Yeah. I fell twice in Miami this past February, about 8 days after my last treatment of SBRT. And I've just finished a course of balance training, physical therapy that my PC, my primary doctor gave me. And come to find out, the gabapentin I was taking, it says it's good for unsteadiness. So I think that my problem mainly, because I'm not on any of those drugs you just described, I think my main problem was the gabapentin. And I talked about gabapentin last week. I had scalp pain, and matter of fact, the day after I talked to you guys, when I shaved that morning, the pain had gone down to my face, and I could shaving was painful. So that night, I stopped taking the gabapentin for 5 nights in a row. Last night, I took it again because my pain in my perineum that I was taking the gabapentin for came back also. I had done that one time before, about 6 months ago. So I knew it was going to come back. So I tried to book an appointment with a neurologist, oncologist at the Genova Shore Center, and they haven't called back yet. But the point is that I have balance issues, and hopefully I found out the source, but I'm not totally positive of that.
So I think we know that it's an issue with gabapentin. I think it even got mentioned last week, and hopefully that is the source. With enzalutamide, we haven't heard it before, but now Mark's saying something, and Frank. I was not on enzalutamide, but for me personally, I mean, my balance was never good, and my 3 years on, 2.5 years on hormone therapy really hurt my balance. And I just think that it can affect some people, not everybody, but it can affect some people. Thank you, Mark, for speaking up. And Frank, my advice is to push Mortazavi as hard as you can to see if you can get yourself onto darolutamide, because that does not cross the brain barrier, and you may be much happier on it. And that's what I would do if it were me. I'd be trying to get my doc. Peter, have you? Len's not here, but I mean, you've been on darolutamide a longish time. Do you have any balance issues?
No balance issues. I did when I was on Zytiga 4 years ago, but nothing on darolutamide.
Yeah. Okay. Back to you, Ben.
Joel, did you have more you wanted to say?
Yes, one thing only. I'm taking my 3rd PSMA tomorrow at 2 p.m. at the Univ Shore Center. I'm sorry, at the Metro Pet Center, rather.
Good luck.
Thank you.
Okay.
Mark Valens is next.
Oh, just a quick update. I had my first meeting with Dr. Borno, UCSF medical oncologist, about 3 hours ago, and she's totally in support of the idea of stopping Lupron, stopping Xtandi. She's not worried at all, and so that I'm due for my next Lupron in 2 weeks, so I just won't get it. And she said, keep taking Xtandi for 2 more weeks and then stop that. And then it's just a matter of monitoring. But she said, not until we start getting any kind of doubling within 10 months would she worry about it. And she's, it's going to take a while to come back, for testosterone to come back. She described it like a little dimmer. After a few months, the dimmer may start cranking a little bit. But she's hopeful that, a year from now, I'll still be off of it and I'll have more energy, and I'm looking forward to it. That's it.
That's great. That's great. I hope it works out for you.
How did you like? Give us a report on Dr. Borno.
She is so incredible. I mean, she had, it's the first time I met her, but she had obviously looked at all my records, and she's like right there with you, and she takes all the time to listen to you, and she's got great ideas. I mean, fantastic experience.
She has an amazing personal story. I don't know if you know.
No.
At some point, I'll post a link. She was a refugee. She came to this country as a refugee. Anyway, I had a question I was going to ask you. You were among those people who resolved to do more exercise a few weeks ago.
Yes.
How is that going?
Well, thanks to Jimmy's little tough love, I'm at least, I'm getting my heart rate up to over 120 for almost half an hour, 4 or 5 days a week. Plus, I'm doing some other exercises, so I'm working out 5 to 7 days a week, and it's so I'm getting there.
That's great. That's great. Good for you.
Among all the other good things that the exercise does for you, since I can tell you're excited about return of testosterone, it will encourage that.
Good.
It's helpful to your body. It's an assist in that realm, and will just make you feel better at testosterone. You won't be depending on the testosterone alone to make you feel better, and I think that's a big deal.
I just have to deal with some sore muscles, so I'm using some muscles I haven't used too much for a couple of years.
That's okay. You'll deal with it. You have to invoke the athlete's friend, ibuprofen.
Well, I know
Okay.
I haven't even needed that, but thank you guys, and thank you, Jimmy, for a little nudge.
Mark, I just wanted to say that I'm really happy to get that report on Dr. Borno, because I've always suspected that, but we've never really had people that have seen her. I mean, Peter had some interaction with her, but it was really in a very sad situation and very late in the game. And I've always suspected from watching her that she's really great. But we just don't have enough people that see her. And we have a great relationship with UCSF. So I'm curious, Ben, what country did she come from?
I have to look it up. It may not have actually even been specified. This was toward the end of an interview that I think PCF set up with her. I think Ryan was talking with her. Yeah, I'm not sure that they mentioned.
Yeah,
she was very open.
She came to UCSF.
Oh, go ahead.
I was just going to say, I think she came to UCSF right around the time
audio is failing, Rick.
We may never know when she.
That Chuck left to go to Minnesota. Maybe they crossed.
Rick, we're not hearing you. You're breaking up terribly.
So, I mean, he might have been involved in hiring her. It was about 4 or 5 years ago.
No, I'm just going to say she said, invited me to use my chart whenever. If I have more questions, just send them her way.
It's all great to hear. Thank you, Mark. Anything else for Mark? Al Latimer, you are next.
I'll turn my camera on. I keep it off because it seems to work better when I'm not using it. A quick update. I guess you all know that I've already been through the lutetium program. I had the 6 treatments at UCLA, and the last one was in January. My PSA went from 60 when I started to 1.5 at the end of January. And since then, I've had 2 more PSA tests. One a month later when it went from 1.5 to 3. And now I got a PSA test back today where my PSA went from 3 to 4.4 in 2 weeks. So my holiday from PSA has obviously ended at this point. I have a virtual meeting with Dr. Scholes tomorrow, and I guess I'll see what he says. So I'm kind of, if anybody else out there has any ideas about where I should go next, what I should do next, something I should bring up with Dr. Scholes, I'm at this point, I'm all ears. But that's where I stand at the moment. By the way, I'm feeling fine. I mean, I don't have any symptoms from the cancer. The symptoms are all either side effects or side effects from meds. But I've actually never had any side effects or any pain issues from the cancer itself. So anyway, the beat goes on. We'll see what's next.
What are you taking now? Anything?
Well, I'm on my version of ADT, which is I'm using estrogen rather than Lupron. And the doctor has also put me back on abiraterone, so I've been doing that.
Okay.
And as well, I've been on that for 2 weeks now. That's why I had another blood test so soon, because they wanted to check my liver function after 2 weeks. And I'm also on, oh, my mind just went blank. It'll come back to me. So, but my testosterone is 0.5. So I don't have a testosterone issue, that's for sure. Well, I guess I will let you know what Dr. Scholes says tomorrow, where I should go from here. I know he had talked about Provenge, but maybe at this point I need to be more aggressive than that.
Well, Herb feels you should do Provenge anyway. He did it right before doing lutetium because it was better than the other options that are available, and it might help. He's not here, I guess, huh? No, he's not here to talk about it. I missed something. You were on lutetium, right? Was that what you said?
Yeah, I did the lutetium 177.
Well, can they do it again?
They can do it. They talked that it was possible to do it again. I mean, I've only been off it 2 months now.
Yeah, it's not ready yet, I don't think. But I just wondered if you talked about that.
Yeah, the doctor at UCLA says that they have repeated it in some situations, but with lesser success. And in my situation, I only had the first 4 sessions of lutetium, my PSA dropped quite a bit. Actually, the first session, it dropped about 80% on the first session alone, and then progressively less down to 1.5. But after the 4th treatment, I got no further benefit out of it. I get no further decrease in PSA, but the dry mouth got worse and worse. And it has subsided somewhat now, but I don't know how much more lutetium I could take. The dry mouth got pretty severe.
I just wondered in the future. How long have you been on the Abbey?
2 weeks.
All right. When I was on for 2 weeks, my PSA actually dropped, but it didn't drop again until a year and 3 months later. It started dropping. I mean, I'm at 0.3 now, so you never know what it'll do. Have you been on Abbey before?
I was.
Did it stop working?
Yes, it stopped. Well, it was complicated. I was having blood pressure issues at the time.
I know. Yeah.
And it was never proven that the Abbey was the problem, but I did stop it.
Yeah, it's hit my blood pressure pretty hard as well. I just wondered it may help. I mean, it may, stop metastasis. Have you had another PSMA? Oh, you're not high enough yet.
Well, I had another PSMA PET about a month ago, and substantially all the Mets that were shown before had disappeared. I mean, the scan there was 2 suspicious areas, but most everything had cleared up.
What was your PSA when you did that?
1.5.
Oh, great. The Abbey may then stop the metastasis from growing further. That's probably why the doctor put you on it, right? That's one of its big.
Well, he said that there may be some cancer out there that will respond to it. So he thought it was a good idea to add that to the mix before. I'm already working on getting the Provenge going.
Great.
So I expect to be able to start that in the next few weeks. I actually was already approved for it a year ago when lutetium came along, and I put that on the back burner. But now that my PSA is rising again, I understand I'm eligible to do it. So, but that's in process right now. I was supposed to have already seen the doctor last week about it here locally here, but the appointment got changed until next week. So at this point, I don't have anything more to report on that.
It'd be interesting to hear what happens over the next couple of months. That'll tell what's working. I suspect.
When I was on the trial at Weill Cornell with actinium and 2 other medications, they did clearly indicate that dry mouth was a side effect. So I understand it's not only actinium, but it is also lutetium. And they recommended a dry mouth oral rinse called Biotene, Biotene, which you can get pretty much in any drugstore.
I have Biotene. I have Biotene in every form it comes in, including toothpaste and spray and lozenges. And I was using it constantly at first, but now I've kind of backed off of it a little bit because it doesn't seem to be quite as severe. But yes, Biotene has been a lifesaver.
So I did want to jump in with a couple. I'm sorry, I lost my connection there, and so I don't know if this was discussed, but unfortunately, the elephant in the room is the same one that Carl wrestled with. It might be the same elephant who's found its way further south. If you're in Sarasota, I would definitely think it was the same elephant.
No, I'm further south than Sarasota.
I know. Well, Sarasota is where Ringling Brothers' winter home is, you know.
Oh,
So,
okay. I didn't get that.
Okay. And that is that at some point you probably need to consider doing some chemotherapy, and especially if you want to revisit Pluvicto, because you're not going to get that, be able to get that.
Oh, there goes Rick again.
Ben, you gotta,
Can anybody?
you gotta stop muting them.
Pluvicto definitely is not going to be given without chemotherapy prior, as of
Okay,
now.
well,
I've heard that from two patients who are two friends who were having to start chemo when they didn't want to, so they can get Pluvicto.
Well, so when I started at UCLA, I had not had chemo yet, and for one reason or another, I don't know, I got accepted anyway. So I have never had chemo.
That's the clinical trial aspect. I believe that in the trials, they can do whatever they want. I think with respect to using Pluvicto as standard of care, it's different.
I was not in the clinical trial. I was in a
managed access.
Managed access, that Novartis was doing. And yes, generally speaking, they were requiring chemo first, but somehow I slipped under the radar and did it without having chemo. So my response to the to the lutetium was great. I mean, to go from 60 to 1.5 was a really good response. But it has not been durable at all. So I was thinking about trying to contact the doctors in Australia who have been using this longer and may have more insight on what to do when it fails. I tried contacting them, and they said that I had to have a referral from my doctor. So that's something I'm going to ask Scholes about tomorrow.
You might want to contact Ken Anderson. He just came back from Australia, and he's got a number of friends over there who've been on lutetium, and
is that right?
Thinking of doing it over there. So he might have some contacts or know some people. He's back in Phoenix now.
But I emailed the group that Dr. Hoffman is with, and anyway, I didn't get a response right away, but I don't know, maybe Scholes has a contact over there. Any little tidbit of information I can get now would be certainly would be great, because I realize I'm in way out at the edge of beyond the cutting edge here. But people have already had lutetium and have already failed it. So we'll see.
Is there any info on what percentage of people are successful for a long period of time? I haven't seen those results.
Well, I know the durability is a lot longer than 0. But I don't know the numbers. When I was talking with the UCLA doctor before I started, he thought I could expect up to a year before my PSA started to rise again. So that was obviously overly optimistic.
You'd think we'd see some stats coming out of Germany and Australia, because they've been using it quite a while now.
Well, that's why I'm trying to contact Australia. At least they speak English there, so at least sort of. And well, I mean, I think they've been doing it longer than anybody over there.
Yeah.
So
anyway. Doesn't Ken have an AnCan email address?
Sure. Yep.
Yeah.
Can I find that on?
Yeah, we'll find it and put it in there. I can't remember what it is.
Okay, all right, that would be great. I appreciate that.
I thought I had heard
I
Germany.
thought I had his phone number, but I don't.
That Germany has a few places giving it.
What has your doctor said about having chemo, considering you have so few Mets right now? Have you talked about that?
Well, that's going to be part of the discussion tomorrow, whether maybe at what order, at what point in time should I do things I haven't done yet.
Yeah.
I mean, I like the holiday I've been having from med. Well, the lutetium, I didn't really have much of any side effects other than just the dry mouth. I mean, it's been, well, that, and we live in Florida. I went to California 8 times in the last year for this lutetium stuff. So a lot of travel involved. So anyway, I see Dr. Scholes tomorrow, and I'll have another report in another week. Appreciate your time. And the tip for Ken Anderson, that'd be great.
I did put in a link for for Michael Hoffman at the Peter Mac Cancer Center in Australia. So that's in the chat.
Yes, I see that. I actually already have it, and I've already emailed them about trying to get a virtual visit at least, or get their take on what's going on and what they might be doing for patients that have failed. Because they must have, at this point in time, they've been doing this for years. They must have a lot of them by now. So yes, I see the phone number and I see the link. Thank you.
Is Ben still here? Wow.
Ben, we can't hear you.
Can't hear you, Ben.
Bummer.
Our moderators are dropping like flies.
Is there anybody else that was going to talk today? Maybe we could move on.
Good idea.
I can talk.
Go ahead, Larry.
Oh, Rick came back.
So, yeah, I'm back to my old story. Can I share my screen to show my PSA? Is that simple or complicated?
Hit share screen. Hit the screen. I don't know, or maybe not. Maybe you can't do it. If
You can just put the image in front of your camera for now, unless it's you're using a computer, so it's.
No, it's okay. I can do this. Can you see my PSA over?
Yes.
Yeah.
So actually, this is when I started getting mid Sloan. I was back the end of 2015 when I was diagnosed. See this high number? That was when I stopped Casodex. It dropped right away. I was on after chemo. I was on Casodex and Lupron. And then I had this long, slow thing for a couple of years, and then ups and downs.
Yeah.
Which was very confusing. The steady, like up, down, but slowly rising. Then more recently, from below 0.5, it went up like 1, 2, 3, 4, 5, 6 times one drop, but 6 basically rises. And I got to this point in February, and I thought, okay, now I have to pull the trigger. And the trigger for me was going to be adding darolutamide to the Lupron. That was the basic plan. I was in Mexico for a month, and the PSA dropped from 0.9 to 0.66. So we just decided to watch it more carefully, like every month, and see if it rose again. And then it rose again to 0.88 just more recently in April. So that's, to me, pulling the trigger time again. Here's my question. You know, I had the technician, the scans to be allowed to switch to darolutamide. Didn't show anything. And I'm planning to get the Polarify. It's the timing. I'm thinking that I should get the scan before I add the darolutamide, because maybe there is some whack-a-mole to play. There's some, some specific place to try to zap, or two places, maybe not. So that's the question, is to do the Polarify first. And then I was thinking, maybe even before that, I should stop Lupron briefly and see what I can get from the scans. And then to go to the darolutamide and maybe skip adding the Lupron. That's the pathway I'm debating. The question is, once you're taking Lupron and darolutamide, are you masking metastasis? Is that a
Well,
risk?
I don't think you're necessarily masking it, but your PSA could drop too low to pick anything up. If it was me, I'm in the same situation kind of, and I would definitely go for a PSMA scan while your PSA is up a little bit before you go on another drug.
And then was the other question, I'm thinking to stop Lupron before I add darolutamide. After the scans don't show anything that I radiate, then I was thinking about just not showing up for Lupron and switching darolutamide first. Or would you suggest like staying on both for a little while? Make sure it really drops and then cut out the Lupron. I don't know. That's the pathways I'm thinking about, and just didn't know if anybody had.
Well, nobody here's a doctor. Nobody's going to tell you what to do. I wouldn't do that either.
I don't want to know.
Yeah.
I just was curious about like what people are thinking.
We could say though that there are no official indications for darolutamide monotherapy in existence. Would that be fair to say?
Yeah, well, it's not the protocol. My doctor's aware of my plan to try to just follow that pathway that Lan is on, that Peter looked at, that others have thought about. I'm thinking about following that pathway. Maybe I want to start them both together and then just skip the next Lupron, if it drops precipitously. But I guess I should get a Polarify first and think about doing radiation if I see something very clear, and then go on that pathway. I don't know. Am I making sense?
Yeah.
Yeah, I'm also curious about how they even decided to be on darolutamide monotherapy. I mean, it's worked out, but how did they even decide that?
You got to have a doctor that can work with you. You have to have a doctor that's going to work with you and not just on the desk and tell you what to do.
No, my doctor will let me try that. She understands that's my plan. It's not her protocol. But she says it's fine if I want to try it. If it rises, I think about adding it. It just won't show up. I mean, she'll suggest I do both. I'll tell her I'm not, and then just start the darolutamide and stop the Lupron if it works. Anyway, that's the pathway that I'm on. Does it make sense?
Yeah. Have you done Provenge, Larry?
No, we keep talking about, you mentioned that a number of times. I have that floating around in my brain since 2016 or something, but I haven't done it, and I'm a little leery. I mean, I understand even my doctor recognizes that it's kind of proven beneficial. I'm wondering if there's something else in the pathway that might come along instead, and I don't really understand. I mean, I hear explanations of what people think it's doing, that it may block the cancer from metastasizing, but not lower your PS, variations on that. But I'm not really clear exactly what, Prevenge does, other than the same way I'm not clear about what BAT value is either. So I just am like, I don't know. I'm already like in a confusion about what to do and don't want to complicate it.
Get blood tests monthly.
What? Sorry, Jimmy.
Get blood tests monthly. You want to,
Yeah,
if you're going to change this,
yes,
you were
we
doing
just,
it quarterly.
yeah, we were, but look, you see, February, March, April, we just switched. January, February, March. We switched to monthly right now because of the weirdness of dropping and rising. But it's high enough. I'm tired
So,
of playing the game
so
around.
Larry,
Yeah.
the evidence for Provenge over a long period of time is pretty strong. And it was presented to us several months ago, and Herb and Len can speak to it better. It stimulates the dendritic cells, which, as I understand it, generate more T cells. They help the dendritic cells interact in your immune system to boost the T cells, and you get more T cells, and so it fights the cancer. Now,
PSA.
I can't be more technical than that. But I do recommend you watch Larry Fong's last webinar to us, because he explains it on there, and he's the guy that discovered it, invented it, back in, before 2010. And the one thing I can say is it's like chicken soup. It can't hurt, and it may help. And I don't think, and it doesn't have side effects, so I don't think that there's much to think about.
I don't know if it has implications that nobody knows about. It's not like,
yeah, but come on, man, it's been around for 12 years. If there were implications, we would know about it. That's like saying, I don't know if lutetium has things we don't know about. Maybe it does. But if people have been getting Provenge for 12 years and we don't have any adverse reports, then to me, if you're questioning whether it works and what it does, then you're not reading the literature and absorbing the literature, because there is evidence there. It isn't great evidence, because Dendreon ran out of money, and then they were bought by the Chinese, and the Chinese have never been good about sponsoring trials. And so do we have great evidence? No, but we have enough evidence to know that now's the right time for you to get it. You don't want to be getting Provenge when you've got rampant disease and your PSA is shooting up. So now's the time. And
I know that that's the reigning AnCan opinion at this point, but it's not yet my opinion that now is exactly the time. I don't know how long I can wait. I don't like
the earlier you get it, the better you are.
What?
Say that again?
I like to minimize what treatments I get. I know that doing full onslaught attacks from every direction may be beneficial in the long run, but I've been enjoying my life for.
Yeah, but Provenge is not going to affect your quality of life. It's certainly not going to affect it anywhere near as much as even darolutamide.
Rick,
Peter just walked away, unfortunately, but
I get beat up on this. I'm just telling you that I'm going to hold off for a while.
okay. I mean, if anybody else has had Provenge and wants to talk to Larry, please speak up. But it's a pretty benign treatment.
I know that it's Herb, Len, Peter, you. I hear you guys. I'm not ready to do that at this moment.
Okay.
I hope I'm okay. I hope I'm okay with that. I want to go ahead with the Polarify potential radiation darolutamide. See if my PSA really goes up. And then if it starts to climb again, I would run to do prevention. If it doesn't drop, probably would do it also. But if I can drop my PSA way down, I want to hang with that for a while.
Well, something like Provenge could have an impact. We don't know, but we do know over the long run that it certainly increases overall survival. We know that.
I think I agree with that. I don't know that it's necessary to do it at this moment.
Ben's having trouble with his audio. I'm back here, so I'm happy to take over. I wanted to talk to George Denyon, who's been sitting there very quietly and listening. Because I have, and Soleil, this is your meeting starts in half an hour, dear. The multiple sclerosis meeting starts at 5:30. Okay, come back soon. But you can stay and listen if you want to listen. But this is a different meeting. Okay, don't worry. You're muted as well. We can't hear your beautiful French accent, so you're muted.
I just feel this old man.
This is because we're talking about prostates, but you can listen if you want to listen.
Yeah, I kind of know what it is.
Okay. Let me get to George. George, I got some very interesting news yesterday. I haven't had a chance to, because of my crappy internet, I haven't had a chance to share this with you. But there are 15 sites right now that are delivering, according to advanced accelerator applications, there are 15 sites that are delivering Pluvicto right now, and one of them is Duke. So now the other one, I'm just looking for my list right here, which I had on my hand just before, and of course now I don't see it. But there is also a site in Maryland that is that's delivering right now. I'm trying to remember the name of it's south. It's on your side. It's on the south side of Baltimore. Well, let me see if I can at least come up with the full list. So what I wanted to tell you, I got it. Okay. So advanced molecular imaging in Maryland. And they are, the name of the town will come back to me. I had it on my screen and Steve Safter's left, but somebody can look it up. Dana-Farber, Duke, Highland Oncology in Arkansas, Marshfield in Wisconsin, Seattle Cancer Alliance, St. Francis on Long Island, University of Florida in Gainesville, Mount Sinai in Miami, the University Cancer and Blood in Athens, Georgia, University of Chicago, Virginia Cancer Virginia Cancer in Fairfax, the VA in Los Angeles, Excel in Houston, and Austin Radiological also in Texas. So those are the places that have right now that can deliver PSMA according to the FDA approval. And if you go to the AAA Patient Connections program, there is a link in there that has all the CMS codings. So if your doc says, oh, it doesn't have CMS codings or we can't do it, that's not the case. So you can call in. So anybody who is eligible and wanted to get it right now, those 15 places have all taken deliveries according to AAA. There's a bunch more that are in the pike, but they haven't ordered the drug yet. So, George, I wanted to be sure that you knew that Duke and this other place in Maryland, did anybody figure out what the name of the place in Maryland is? It's on the tip of my tongue.
Website's there. I put it in the chat, Rick. It's Glen Burnie, Maryland.
Glen Burnie, thank you. So it's in Glen Burnie, George. So I think that you should have a little chat with Kaiser if they're willing to recommend. Don't wait on Hopkins, because Hopkins administration is horrible. Either do it with I know you is horrible.
There you go.
George soon.
You're going away.
Rick,
So either work it out with
you're
Danny
breaking up.
or have Kaiser send you up to Glen Burnie I mean, how far is Glen Burnie from you?
It's probably a little over, about an hour, maybe. Yeah.
Okay.
But Kaiser did,
so you know,
did approve me to go to Johns Hopkins. I got word of that yesterday.
It looks like I do have audio again.
You do. Looks like we're struggling a little bit here at the tail end.
The meeting's over, Ben.
I think the meeting is over in all but name. Good night, everybody. Apologies to those who came late. John Antonucci, Carl Foreman, Rich Jackson, Stan Friedman, Russell Hoover, Don Kramer. We'll get you next time.
Thanks for stepping in at the last minute. Literally the last minute, Ben. Good job.
My pleasure. You're welcome. Thank you, everybody. Good night.
Good night. Good night.
This conference will